In this video, we'll talk about EKG reading protocol, which is the same protocol that Dr. Paydak, who is one of the electrophysiologists, teaches his medical students and residents to read EKG systematically. To start with EKG reading, we will focus on 6 sections. The first section is the rhythm. In the rhythm, first we have to determine if this is a sinus rhythm. Sinus rhythm means we have a P wave that is positive in lead 2 and is negative in AVR. Just like in this EKG, if we look here, it's positive in lead 2 and it's negative in AVR. So this is sinus rhythm. Okay. Next, we want to determine if there is a sinus arrhythmia or not. So if the RR interval is slightly regularly irregular, this is called sinus arrhythmia. And sinus arrhythmia is actually caused by normal physiological inspiration and expiration. So if we look here at the RR interval, and this is the RR interval here, it's prolonged here more and more prolonged here. And after that, it goes shorter, just like this one. And after that, the same one, shorter, the same. So if you can see, there is a slight pattern here. So it's not that great difference between the RR interval. It's just like small changes in the RR interval. And after that, the cycle happens again. We have a prolongation of the QRS of the RR interval. So we can say this patient has a sinus arrhythmia due to recording the EKG during inspiration and expiration. Now, if there are no P waves at all, and the rate is irregularly irregular, it's atrial fibrillation. If we cannot predict what is the next RR interval, we can say this patient has, with no baseline, of course, this is actually atrial fibrillation. Look here, the RR interval, it shortens here, it prolongs, shortens, same, prolongs a little bit, or like shorter than the previous one. So this is irregularly irregular, and there is no P waves at all at the baseline. So we can say this patient has a atrial fibrillation. Number 4, if the heart rate is really rapid, like around 150, with a range of 130 and 170, and there is a hidden P wave halfway between 2 consecutive P waves, we have to consider atrial flutter with 2-to-1 AV block. So if we look at this EKG here, and we look at this P wave here, this is V1. Actually, V1 and lead 2 are the best leads to look at the P waves, okay? Now, there is a P wave here before this QRS complex, and the consecutive P wave is this one here. If we look midway between these 2 P waves, we can see this like positive and deflection here. This positive deflection could be a T wave, or it could be a hidden P wave. If we look down here, it seems to be positive, and this is the T wave. So this is a hidden P wave here, okay? And because the heart rate is really high, it's almost like 150 here, because only like 2 large squares between the RR interval. So the heart rate is around 150. So we have to consider atrial flutter in this EKG. Okay, so this is for the rhythm. Now let's go to the second part, which is the rate. For the rate, it's very easy. Just count the number of QRS complexes in one rhythm strip. Usually the rhythm strips are found at the bottom of the EKG. And after that, the number you get, you multiply it by 6, and you will have the heart rate. If the heart rate is less than 60, this is bradycardia. If it is more than 100, this is tachycardia. And if we looked at this EKG here, I think the patient has atrial fibrillation. But if you count the QRS complexes here, it's 24. 24 multiplied by 6 is 144. Okay, so this patient has RVR. Now this table is just the multiplication of 6, 12, 18, till 35 multiplied by 6 is 210. So these are the most common numbers that you will be dealing with. With time, with practice, you will just memorize them. All right. Number 3, we look at the axis. How we determine the axis? First, find the most isoelectric limb leads. So here we are talking only about the limb leads, which are lead 1, 2, 3, AVR, AVL, and AVF. 6 leads, you only look at these leads. And you try to find the most isoelectric limb lead. What does isoelectric limb lead mean? Isoelectric means the R wave equals to S wave. So the magnitude is 0, okay? The total magnitude of this lead is 0. Okay, so we try to find the most isoelectric limb lead. And after that, we have to determine the limb lead that is perpendicular to this lead. How we can determine this? By this chart here. Now, it's very easy to memorize this chart. Now, lead 1, the axis of lead 1 is 0. The perpendicular lead to lead 1 is actually AVF, which is positive 90. They are perpendicular. Okay. For lead 2, which is positive 60, the perpendicular lead is AVL, which is minus 30. Now, for lead 3, which is positive 120, the perpendicular lead is AVR, which is minus 150. Okay? So, first step, you determine the most isoelectric lead. Next step, determine the lead that is perpendicular. So, if the most isoelectric lead is lead 2, the perpendicular lead is AVL. If the most isoelectric lead is lead 1, the perpendicular lead is AVF. Okay, so here how you determine which lead you are looking for. Now, the third thing, and this is really very important. Each lead, you need to know the axis of each lead and the opposite number at the bottom of the axis. So, for example, lead 3, the axis of lead 3 is 120 positive. Okay. Now, if we extrapolate a line here and we want to know this angle here, how we can do that? Just remember, it's a straight line. So the total angle is 180, right? Okay. So just ignore the signs. Just ignore the signs. If this is 120, you need to add 60 to get 180, right? Because 120 plus 60 is 180. And you inverse the signs. If this is positive, this should be negative. Okay, this is very important, guys, because now we will know how to determine the axis because of this. Okay, so just to memorize these numbers. AVL, lead 1, lead 2, AVF, lead 3, and AVR. And you can extrapolate the other numbers. So how we can do that? Okay, so for lead 2, it's minus 60. Now, let's look at the lead 2 here. Sorry, lead 3 is minus 60. Lead 2 is positive 60. So the complementary angle that continues continues to 180 is 120. And you just inverse the sign. This is positive, you should put negative here. Okay, and you do it for all the leads. For AVL, to continue to 180, you need 150, and you inverse the sign. Okay, for AVR, which is minus 150, the complementary angle for 180 is 30, and you inverse the sign. Okay, after knowing this, okay, this is very important. Here, how we can determine the axis. After determining the perpendicular lead, now we look at the perpendicular lead. If the QRS complex in the perpendicular lead is mostly positive, then the axis is the number at the head of the arrow. Okay. But if the QRS complex is in the perpendicular lead is mostly negative, then the axis will be the number at the tail of the arrow. Okay, so that's why it's really important to know which lead you are talking about and what are the complementary angle at the tail of each axis. Okay, let's take an example here. If we have this EKG here, so what is the most perpendicular lead? If we looked at them, I think AVR is the most perpendicular one, is most isoelectric one. What is perpendicular to AVR is lead 3. Lead 3 is positive, so we take the angle at the tip of the lead 3, which is 120. Okay, now if the lead 3 was negative, we take the angle at the tail of the 120 of the lead 3, which will be minus 60. Okay, so it's positive here, so we take the angle, the normal angle at the tip of the arrow, not at the tail, which is positive 120. So this patient has right axis deviation. Oh, by the way, if we go back here, any angle, any axis that is greater than 90, this is right axis deviation. Any angle that is less than minus 30, like minus 45, minus 60, minus 90, this is left axis deviation. And this red here between minus 90 and 180 is extreme right axis deviation. Extreme right axis deviation. Okay. So this is the first example. This is the second example. What is the most isoelectric lead? I think it is lead 2. Okay, what is perpendicular to lead 2? It is AVL. AVL positive, so we take the angle at the tip of this arrow. So AVL is at -30. So this is -30. So there is barely left axis deviation. Okay, at the border of left axis deviation. Okay, this is very important how to determine the axis. Okay, after finishing the axis, we have two special considerations for axis deviation. And actually, this is really very important. The first one is if the axis is more negative than -45. So here's -30, -45 is here. So if it is more negative than this, like, okay, if it is negative, more than, it's more negative than -45. For example, like -60, -70, -80, -90. Okay, you have to consider left anterior fascicular block. And we discussed left anterior fascicular block in a separate video. Okay, but you have to support your diagnosis. How you confirm this? You will find small q with tall r in lead 1 and AVL, and the opposite, small r with tall s and lead 2, 3, and AVF, which is the inferior leads. Now, so this is the consideration number 1. Now, the consideration number 2, if you have an axis that is more positive than 110, 110 is here, anything more than that, for example, like 120, 130, 150, 160, whatever, you have to consider left posterior fascicular block. How we can confirm left posterior fascicular block? We find the opposite of this. R, small r, deep S, where in the lateral leads, 1 and AVL, and you find the Q wave R and the inferior leads, 2, 3, and 10. Okay, so this is how to confirm left anterior fascicular block and left posterior fascicular block. Okay. Now, fourth section, so we talked about rhythm, rate, axis. Now we talk about the intervals. For the intervals, you should look at the PR interval, QR duration, and the QT interval. So 3 intervals. Okay, so there are 3 intervals. The first interval is PR interval. PR interval, you measure it from the beginning of the P wave to the beginning of QRS complex. So from the beginning to the beginning. Normal PR interval is 3 to 5 small squares. Here we use small squares, which is the easiest one. And just remember, if you want to convert from small squares to milliseconds, each small square is 40 milliseconds. So you multiply any small squares by 40 and you will get the milliseconds. Okay. So normally it's 3 to 5 small squares. Now, if it is longer than 5 small squares, which is 200 milliseconds, you can diagnose, you can tell that the patient has first degree AV block. Now, if the PR interval is shorter than 3 small squares, you have to consider pre-excitation syndrome, just like Wolff-Parkinson-White syndrome. Okay, and this is an EKG. If we look here at the beginning of the P wave till the beginning of the QRS complex, and we have to measure all these small squares here, 2, 4, 6, 7. So there are 7 small squares. So this is prolonged. So this patient has first degree AV block. First degree AV block. Okay. The second interval is the QRS complex duration. QRS complex duration, normally it should be less than 2.5 small squares. And you have to be precise here, okay? You have to measure it really exactly, like from the beginning of the Q till the end of the S. This duration should be less than 2.5 small squares. Now, and we can say this is narrow complex, which is normal. Now, if the QRS complex duration is between 2.5 small squares and the 3 small squares, okay? It's between 2.5 and 3. This is a very non-specific intraventricular conduction delay. There is a non-specific delay somewhere. Either there is a fascicular block, either there is a refractory right bundle. So the right bundle, you know that the right bundle refractory period is longer than the refractory period of the left bundle. Okay, so maybe you catch the speed at when the right bundle was in refractory period. Okay, so there is non-specific intraventricular conduction delay, and we don't care about this. Now, if the QRS complex duration is more than 3 small boxes, this is prolonged and should be concerned for fascicular block or bundle branch block somewhere, either right bundle branch block or left bundle branch block. Okay, for example, look at this one. If we look at the QRS complex duration, it's really prolonged here, beginning till the end, which is 1, 2, 3, 4, almost 5 small squares. Or here, 1, 2, 3, 4. So there are 4 small squares. So this is prolonged QRS complex. And whenever you have a prolonged QRS complex, you have to think about fascicular block or right bundle or left bundle branch block. And I believe here there is right bundle branch block, RSR prime in lead V1, V2, and there is a slurred S wave in V5 and V6. Okay. There are separate videos for the bundle branch blocks. Okay. So this is the QRS complex duration. The third interval is the QT interval. So how to measure QT? We measure it from the beginning of QRS complex till the end of the T wave. So it's beginning to the end, from the beginning to the end, beginning of the QRS complex to the end of the T wave. Now, if this distance is less than half of the RR distance, the QTC interval is normal. Okay, this is by eye. Just by your eye globes, you can say this is a normal QTC interval. So if the QTC interval distance is less than half of the RR distance, okay. But what if it appears a half or more than a half? What should we do? You count the number of small boxes in the QT and convert them to milliseconds by multiplying them by 40. And this number, you put it either in MedCalc calculator or in on the computer program, and it will read the QTC interval for you. Okay, because we have to use the square root and the cubic root and all these things. We don't care about it. Just use a calculator for it. Okay. So if the QT interval appears to be half or more than the half of the RR interval, you count the number of small boxes in the QT and multiply them by 40 to get the QT interval. And you put this number in the EKG program to calculate the QTC interval. Okay, now QTC interval normally is less than 450. This is the normal. But if you have fascicular or bundle branch block, we accept QTC interval up to 500. Okay, this is very important. Okay, so in all cases, the QTC interval is up to 450, except for blocks. If there is fascicular block or bundle branch block, QTC interval may be up to 500 milliseconds. Okay, how to read this EKG now? Let's see. Let's see here. You can take any QRS complex, but you need like a good T wave to determine the QTC. So from the beginning of the QRS complex till the end of the T wave, this is the duration. If you count these squares, it's almost like 10 or 9 squares here. Okay, and the RR interval is from here to here. So by eye, you can tell that this distance here between the two red lines is less than a half of the green distance, which is the RR interval. So this is normal QRS complex. Sorry, normal QTC. Okay. So now we finish the intervals. Now we go to the morphology. In morphology, you have to determine the R wave morphology, QRS complex morphology, and these are the most important things. So the P wave and the QRS complex morphology. Let's talk about them. For the P wave morphology, we are concerned about two things: left atrial enlargement and right atrial enlargement. So in the 5th section, you look at the morphology of the waves. For the P wave, we are concerned about left atrial enlargement or right atrial enlargement. How we diagnose left atrial enlargement by EKG? We have 2 criteria. You need one of them. And remember, P wave are greatly examined either in lead 2 or V1. These are the best leads for the P wave. Okay, so you look at P wave in lead 2. If it is at least 3 small squares wide, this patient will have left atrial enlargement. Or if you look at the P wave in the V1 and it has a negative component more than 1 small squares, then the patient have a left atrial enlargement. Let's look at this EKG. Okay. If we can look here, at lead 1, we have the biphasic P wave. And by the way, at lead 1, P wave is normally biphasic. Like you can see, positive then negative, positive then negative. If the negative vector of it is more than 1 small square, this is left atrial enlargement. Okay, and if you look here, if it is wider than 3 small squares, it is left atrial enlargement. I think it's not. Okay, so only we need one criteria only, right? So this patient has left atrial enlargement. Okay, and this is number 1. Number 2 is right atrial enlargement. Right atrial enlargement also has 2 criteria. If the P wave is greater than 2.5 small squares in height, it's more than 2.5 small square tall. Okay, in lead 2, or the P wave positive component is more than 1 small square in V1. Either which one of them will give you the diagnosis of right atrial enlargement. Okay, let's take another EKG. We look at this EKG here. If you look at the V1 and you look at the positive component of the P wave, it is more than 1 small square. So this patient has right atrial enlargement. Okay, so the patient will have right atrial enlargement. And if we look at lead 2, I think it is less than 2.5 small squares. So it does not meet the first criteria. So only you need one criteria, right? So this patient has right atrial enlargement. All right. Number 2 in QRS on the morphology is the QRS morphology. And in QRS morphology, we'll talk about these 4 things. This is very important. We start with the R wave progression, then to look if there is ventricular hypertrophy, either right or left, then low voltage criteria, and last of which is the pathological keywords. Okay, so what about the R wave progression? R wave progression is good, so we can say this is a good R wave progression if the R wave perks up, meaning that it competes or beats the S wave in lead V4. Okay, so if R wave is longer than S wave in V4, this is a good R wave progression. Okay, let's look at this EKG. Normally speaking, by the way, this is normal. Okay, normally speaking, in V1, the R wave is very, very minimal, very, very tiny. And after that, it started growing up in V2, growing up more in V3, and in V4, it will be greater than the length of S wave. If you measure it, it's more than, or at least slightly longer than the S wave. Okay, so this is good R wave progression. Okay, this is good R wave progression. So always in the EKG, we look at the R wave progression in V4. Now, if you find there is bad R wave progression, and you can see this in 2 scenarios. Number 1, if you recognize RSR prime in V1 and V2, this is right bundle branch block only if the QRS complex duration is more than 3 small squares, which is 120 milliseconds, okay? And we talked about the right bundle branch block in a separate video. Okay, this is only revision, how we read the EKGs. Okay, but if you find the RSR prime in V5 and V6, this is compatible with diagnosis of left bundle branch block only if the QRS complex duration is more than 3 small squares. Look here, we never diagnose right bundle branch and left bundle branch block without a broad QRS complex. QRS complex should be broad. Okay, this is number 1. Number 2 in QRS morphology is ventricular hypertrophy. And when we're talking about ventricular hypertrophy, we have 2 types of hypertrophy, either right ventricular hypertrophy or left ventricular hypertrophy. For the right ventricular hypertrophy, we have only one criteria. If the R wave is bigger than S wave in V1, if you remember, shortly we talked about the V1 and we said that R wave is very tiny in V1, very, very tiny. And majority of the QRS complex is as S wave in V1. Okay, now, if you looked at V1 and you find a R wave that is longer than S wave, this is the only criteria for right ventricular hypertrophy. But keep in mind, this is actually very rare. Okay, so if you see this pattern, that the R wave is bigger than S wave in V1, consider lead misplacement of V1 and V2. Okay, sometimes we misplace them. V1 in place of V2 and V2 in place of V1. So V1 will show the picture of V2, like the R wave is a little bit longer. Okay, so consider this. But if you are sure that there is no lead misplacement, there are some features that are supporting the right ventricular hypertrophy. For example, if you find right axis deviation and right atrial enlargement, okay, this is supporting for right ventricular hypertrophy. And let's look at this EKG. If we look here at the V1, weirdly, the R wave is much longer than the S wave. Okay, R wave is much longer than S wave. But if you look here, we still can see there is another thing that is called the right ventricular strain pattern, which is ST segment depression with T wave inversion in the anterior leads, V1, V2, V3, and V4. And if we have the rest of the EKG, we can say that there is right axis deviation as well. Okay? All right. So these are things that are supporting the right ventricular hypertrophy. Okay. Most importantly, more than the right ventricular hypertrophy is the left ventricular hypertrophy. We have 4 criteria, okay, to diagnose ventricular hypertrophy, left ventricular hypertrophy. One of them is sufficient. So you need only one of these criteria to be positive to tell that the patient has left ventricular hypertrophy. Number 1, if the R wave is greater than 16 small squares in lead 1, or the R wave is greater than 20 small squares in lead 2, or R wave is more than 11 small squares in lead AVL, or if you measure the S wave in V1 or V2, the longer one, and you add that to the R wave, the longest R wave in V5 and V6. If the total is more than, equal or more than 35 small squares, this is a left ventricular hypertrophy. Okay, so let's take an example. If we look at this EKG, let's look at lead 1 first. Lead 1 is one large square, which is 5 small squares, 10, 15, 20, 21. We need only 16. So this is left ventricular hypertrophy, and this is sufficient. We don't need any other. We don't need any other criteria. But let's continue to see. Let's look at lead 2. Here, R wave should be more than 20. This is not 20. Okay. Let's look at AVL. AVL should be more than 11 small squares. This is 5, 10, 16, 15, sorry, 16, 17, 18 maybe. So this is also left ventricular hypertrophy. And the last one, we look at the S wave in V1 and V2 and we get the longest. The longest is here. So this is 5, 10, 15, 20, maybe 25. Plus, we go to V4 and V5 and we decide on the longest R wave. I think they are the same. So let's take this one. So this is 5, 10, 12, plus 12. When you measure them, these are 37, which is greater than 35. So this is also a positive criteria for left ventricular hypertrophy. Okay, so it's very easy. All right. After that, we look at if there is low voltage. Low voltage has 2 criteria. One of them is sufficient. Number 1, you look at the QRS complex in all lamp leads, AVL, AVF, AVR, lead 1, lead 2, lead 3. If all the QRS complex in all these leads is less than 5 small squares tall, this is low voltage. Or if you look at the precordial lead, V1 to V6, and all the QRS complexes in all of these leads are less than 10 small squares tall, this is a low voltage. And we know the causes of low voltage, either obesity, pericardial effusion, pleural effusion, COPD, anything that can make the distance between the heart and the chest wall larger, okay? And let's take an example. If we look at the lamp leads, lead 2 is really longer than 5. So there are no low voltage criteria by the lamp leads. But if we looked at the precordial leads from V1 to V6, all of them is less than, so we start from the peak of the R to the peak of the S, okay? Less than 10 small squares. All of them is less than 10 small squares. So this patient has a low voltage criteria for low voltage criteria, okay? And we have to investigate further. Good. And last of which, we look at if there is a pathological QF. Pathological QF are easy. The definition of pathological QF, if it is greater than 1 small square in width, and the depth is greater than 1/3 of the entire QRS complex. So if the entire QRS complex, we measure it from the peak of the R wave to the bottom of the S wave. Let's say it's 9 small squares. So the Q wave to be pathological, it should be at least 3 small squares, which is 1/3 of the QRS complex duration. Okay, so again, pathological Q wave, it's greater than 1 small square in width and more than 1/3 of the entire complex QRS complex. This is pathological Q wave. Now, pathological Q wave signifies ischemia, but you have to support this by contiguous leads. They should be in anatomical pattern. For example, inferior infarct, you will find the Q waves in lead 2, lead 3, and AVF. You have to see them, the Q wave in all these 3 leads. Okay, especially in lead 3, guys. Sometimes you can see lead 3, and you can see a Q wave in lead 3. This is actually due to the EKG being recorded while the patient is taking an expiration. Exhaling the air from his lungs will give us a small Q wave in lead 3. Okay, so you need the contagious leads like 2, 3, and AVF. Okay. In septal infarcts, you have to see a Q wave in V1, V2, and V3, and V3 should be included. If only Q wave is seen in V1 and V2, this is not ischemia. V3 should be included. And lateral infarcts, you will find the Q wave in lead 1, AVL, V5, and V6. Okay, and this is very important. Okay. Last thing to look at the EKG is the ST segmented changes. And we have 4 things to look at the ST segment. Number 1, if there is symmetric T wave inversion, like this one here, this is symmetric. This is inverted and symmetric. Okay, it could indicate ischemia or injury. Number 2, if there is asymmetric T wave inversion, like this one here, if you look here, it's asymmetric. The first half is not equal to the second half. Okay, if you find asymmetric T wave inversion with ST segment depression, this is likely due to strain from left ventricular hypertrophy, because when the muscle is really hypertrophied, there is a strain on the heart. So you will find some ST segment changes, like asymmetric T wave inversion. Number 3, if there is ST segment elevation or depression, okay, you have to indicate STEMI or non-STEMI. And if there are peak T waves more than 10 small squares, like 2 large squares in the chest leads, V1 to V6, this could be due to hyperkalemia. And this is the systemic way to read an EKG. Thank you.